The abdominal examination follows these key stages: history, inspect, auscultate, percuss, and palpate. In order to perform this examination properly, you should have a good source of light and full exposure of the abdomen. The patient should be comfortable with their arms by their side in a supine position. It may be useful to place a pillow under their head and slightly flex their knees. If you identify the need for a focused abdominal examination, you need to obtain a gastrointestinal, gynecological, and urinary history. For the purposes of the examination, we'll divide the abdomen into 4 quadrants, as shown here. They are the left lower quadrant, left upper quadrant, right upper quadrant, and right lower quadrant. In order to describe the location of pain, etc., there are also a number of landmarks it's useful to be aware of. These include the costal margin, xiphoid process of the sternum, midline, umbilicus, anterior superior iliac spine, and the superior margin of the os pubis. Inspect the patient for signs or symptoms of systemic disease, for example jaundice or cyanosis. Then inspect the abdomen by looking at the contours and symmetry for any abnormalities. This should be started from the side, with the patient in a seated position initially, and then supine. You're looking for conditions such as spider nevi, discoloration of the umbilicus, Cullen's sign, Gray-Turner's sign, hernias, aortic pulsation, and distension. The next step is to auscultate for bowel sounds. These are heard as gurgles or clicks and can occur between 5 and 35 times a minute. The absence of bowel sounds can only be confirmed after 5 minutes of continuous listening. Fortunately, bowel sounds are generalised, so can be assessed by listening in one place, i.e. just to the right of the umbilicus, but if there is a concern, listen in all 4 quadrants. Examples of abnormalities include high-pitched tinkling sounds, suggesting intestinal fluid under pressure, as you'd find in an early obstruction, and decreased bowel sounds, which are associated with peritonitis. The next step is to check for bruits over the aorta area and the renal arteries. Percussion of the abdomen is often used to assess the size and density of the organs in the abdomen and detect the presence of fluid or ascites. It can also be used to validate your findings when you palpate in the next stage of tests. You should assess for dullness and tympany. Dullness is heard over solid organs and masses, whereas tympany is the predominant sound where air is present. Adopt a systematic approach to percussion of all 4 quadrants. It's also possible to percuss the liver span by percussing from thorax to abdomen in the right mid-clavicular line. Next, palpate to assess muscle spasm, the organs of the abdominal cavity, abnormal masses, fluid and tenderness. It's important to look at the patient to note any tenderness during palpation. Start with systematic, light palpation using your fingertips over all quadrants, pushing no deeper than 1 centimetre. Here you're assessing for parietal tenderness and guarding. If guarding is witnessed, this may indicate peritoneal irritation, and you should proceed with more caution. Moderate palpation is carried out over all quadrants using the side of the hand, and this is useful in assessing organs that move with inhalation. For example, it's possible to palpate the lower liver border under the right costal margin on inhalation. Deep palpation using the palmar surface of the fingers is useful to delineate organ borders and identify any abnormal masses. During palpation, it's important to be aware of the underlying organs that may be causing pain or discomfort. In addition, there are specific tests that can be carried out, such as tests for Murphy's sign for cholecystitis. To test for Murphy's sign, start off in the lower right quadrant and palpate until you feel the liver border. Ask the patient to take a deep breath, and as they're breathing in, push in. Ask them to breathe out. If they stop breathing through pain, then this is a positive Murphy's sign. To palpate the spleen, start from the lower right quadrant and work diagonally towards the spleen. Ask the patient to breathe in and then push. Then ask them to breathe out. Normally, the spleen should not be palpable. To identify McBurney's point, find the spot 2/3 down from the umbilicus and 1/3 up from the anterior superior iliac crest. This is where the appendix is. Push down and release, watching for signs of pain which will indicate appendicitis. Find the same point on the opposite side and push down. If you get a pain at the appendix, then this is a positive indication of Rovsing sign. There are other specific tests for appendicitis, such as obturator sign and psoas sign. Balloting the kidneys can be achieved by putting one hand under the right kidney and the other on top of it and pressing them together. Do the same on the other side. Next, if indicated, it's possible to test for kidney tenderness using fist percussion at the costovertebral angle. Here we demonstrate the indirect percussion technique.